Cast is now starting. All attendees are in listen-only mode.
Hello everyone and welcome to our webinar today. We've just hit the starting time, but I can see people are still coming online, so we're going to give it a few more minutes before we get started. Okay, hello everyone and thank you for joining the webinar today. It's a pleasure to host this webinar for you all. My name is Zachary Munn and I'm the Vice Chair of the Guidelines International Network and the Chair of the GIN COVID-19 Task Force. And it really is a pleasure to be hosting this webinar today and to have our speaker, Professor Per Olive van Wyk, presenting on how we can navigate evidence and guidance in a crisis, which we're all living through at the moment. So thank you all for joining. There's quite a few of you still joining the call today. And I'll now run through some introductory slides before I hand over to Per. So just some technical details for you all. Of course, a huge thank you to you all for taking your time to join us today in what is a very, very busy time for many of us. We do hope you have a very good experience today. And what we'd like to do is encourage you all to participate as well. At the moment, you're all in listen-only mode, so we won't be able to have you ask questions verbally, but there is a questions panel which you should see on the right-hand side of your computer, and we will be checking those questions throughout the webinar. So if you have any questions, please do submit them using that questions function. Also, if you'd like to make any comments as well or provide some feedback, this is another way that you can communicate with the host. So please do use that question panel. The other way you can let us know if you're having any issues or if you'd like to contribute to the discussion is by raising your hand as well. So you can raise your hand, and if you'd like to contribute to the discussion verbally, we can turn on your microphones as well. And I think we are going to have some special guests throughout the webinar today. We will be recording this session, and this will be uploaded to the GIN website following this session. And because this is our first webinar in this particular webinar series, we would like and appreciate your feedback on the webinar today as well. And if you could send that on, that would be fantastic. We will be sending out a survey after this as well. So just quickly, a little bit about GIN in case you don't know much about, if you don't know too much about our organisation. So GIN, or the Guidelines International Network, our vision is trustworthy and accessible guidance for better health. And our mission is to lead, strengthen and support collaboration and work within the guideline development, adaptation and implementation community. We do this by providing a network. We are a network of people who are interested in guideline development or perhaps they're guideline users or even systematic reviewers and evidence implementers as well. And we have partnerships with similar and cognate organisations also. One of our main aims is to assist members in reducing duplication of effort by promoting sharing, collaboration and coordination, and building capacity across the network as well in guideline development. So we promote best practice in guideline development, and we also provide opportunities for learning as well through our conferences, webinars, through our regional communities and our working groups as well. We are always we are a very inclusive network and always looking for more people to get involved. So if you're interested in guideline development or implementation, please do get on board with Jin and look at some of the working groups that you may be able to join. But now it is my absolute pleasure today to introduce our speaker for this webinar, and that is Professor Per Olav Vanvik, who will be presenting the webinar today. Per is based in Oslo, Norway, and is a general internist, researcher, and educator and innovator, devoted to make evidence-based medicine work in policy and practice, and he has a key focus on clinical practice guidelines. Per heads a non-profit Magic Evidence Ecosystem Foundation, which aims to provide clinicians and patients with trustworthy guidelines, evidence summaries, and decision aids at the point of care, offering Magic App as a platform. Per is a member of a grade working group and has been on the JIN Board of Trustees since 2014. He's also involved in global COVID-19 activities such as COVID End and BMJ Rapid Recommendations with WHO. And just before I hand over to Per to start off the presentation today, I would like to introduce to you all that we do have our own COVID-19 resources page on our website, on the JIN website, which we are updating regularly for our members, but also for the broader community as well. And here is our COVID-19 page, where you can see we do have a list of resources, so guidelines, repositories of guidelines, systematic reviews and studies, and also some information on guideline development at this time. Our recordings for our webinars will also be uploaded here, and we also have a collaboration board as well, so the network can communicate their plans to each other regarding COVID-19. But now I would like to hand over to our presenter today, Per, who will be discussing how we can navigate evidence and guidance in a crisis. So, Per, I'll just make you the presenter, and you can start us off. Thanks, Per.
Thank you, Zach, and hi everyone. I'm going to show my screen. Let's see. Zach, can you see my screen?
Yes, I can.
Okay, so great pleasure. A bit scary to present this this quite challenging topic today. I think this picture may say more than 1,000 words in terms of the challenges we face in the world today. Yesterday, the CNN broke this news story of Trump's unorthodox treatment choice that flies in the face of evidence. The fact that this is dosing up his hydrochloroquine these days to not get COVID-19. And his statement, "Here's my evidence. I get a lot of positive calls about it," Trump told shocked reporters. It is indeed a massive challenge to navigate evidence and guidance in this crisis. I think a quite unprecedented challenge. And this is the topic of today's webinar. You can see this dashboard from WHO. As you all know, the COVID-19 pandemic is hitting the world hard with an increasing number of confirmed cases, up to 300,000 deaths. This is a few days old, probably even more now. And then the picture below shows what the WHO communicated about a month ago in a press conference where they labeled COVID-19 as a pandemic and infodemic. So they warned against fake news and hoaxes driven by social media and even state leaders. And I would argue that we probably also have an infodemic in its own, driven by our own research and evidence community. This is the number of COVID-19 publications in PubMed in 2020. And you could see at week 20, we had almost 2,500 new publications. This slide is made by Magne Nylund, a great colleague at the Norwegian Institute of Public Health. So the objectives of the webinar today is that in the face of the COVID-19 pandemic and infodemic, we will briefly discuss some core challenges for policy and practice. And then we will look at some rapidly evolving initiatives and resources that may represent potential solutions for us to navigate better. We want to have this as an interactive webinar, and that's the challenge, but we really want you to ask questions, and the SAC will moderate discussions throughout this webinar. And we want to learn from you how you could make use of these resources and even contribute to make them better. And finally, learn how GIN better can contribute to tackling the COVID-19 crisis. So that's the objectives. And then I'll move straight into some tangible challenges for policy and practice on COVID-19. And I think for all of us working on evidence and guidance these days. So some examples include, for a group of hospital managers, what COVID-19 test called RT-PCR should they purchase among the many offerings in the market, and can they trust the results of a positive and negative test? And that, of course, is also a challenge for healthcare professionals and patients. Moving to the point of care, you have this doctor caring for his critically ill patient in the intensive care unit. He's in a country and a hospital where there are no ventilators left. So the question he asks is whether he could offer something called high-flow nasal cannula therapy or high-flow oxygen, and whether that's safe and effective for his patients. And what about risk of transmission of the virus if he offers this treatment? Finally, a few weeks ago, there was a press conference in the White House reporting trial results from the US trial of the new drug remdesivir. The messaging was that this drug was effective, it could be used in practice, the FDA immediately allowed it to be used in practice, and now doctors in the US have to ration this drug, facing nearly an impossible choice. So just a few examples of some clinical and policy questions that together just illustrate what we know to be a medical misinformation mess. This term was labeled by John Ioannidis, who many of you may know, and it is based on the insight that most policymakers, healthcare professionals, patients, citizens do not know that most evidence is quite useless and unreliable for use in practice. And we don't really have the time, resources, or tools to appraise the evidence and use evidence to make well-informed decisions. I think what we can discuss today is whether this mess actually has been enhanced by this pandemic and infodemic. It doesn't seem to be easier to navigate these days than before, and it speaks to the critical role for transforming evidence into trustworthy guidance. So that will be the focus of our webinar today. And if you're curious about these answers, we'll hunt for them during the webinar in the different resources I will present. Now, one way to look at challenges is within this evidence ecosystem that many of you have seen before. And it shows that we are different kinds of people and actors often working in silos, and each step of this ecosystem has particular challenges. So a series of papers in Lancet in 2013 show that most research represents waste. It's actually unreliable and irrelevant for practice, perhaps as much as 85%. Looking to evidence syntheses, systematic reviews may also be unreliable or irrelevant. And John Ioannidis again published a great paper called "A Mass Epidemic of Flawed and Useless Systematic Reviews." Exponential increase also for COVID-19, with the number of systematic reviews perhaps exceeding the number of trials at the moment. And these may take a long time to produce. And those of us turning evidence into guidance for policymakers, clinicians, and patients. We typically end up doing our own systematic reviews, so don't do them at all. And altogether, we struggle with meeting standards for trustworthy and accessible guidelines. Moving all the way down to the implementers and the improvers, those working in the healthcare systems, hospitals, primary care practices, etc., they may not have access to the trustworthy guidance to inform their efforts in improving care. And finally, those evaluating impact may struggle through registries and other tools and resources to really know what's happening in practice. So siloed communities and actors, we really struggle to change the way we work and to work together. Now, this might be a first moment just to breathe and just to check with Zach if any questions or comments have been raised in the questions box, because there may be challenges I have not mentioned yet. So I'll just make a quick check with Zach if there's anything coming up.
No comments or questions yet, Per, but I would encourage everyone to submit their questions.
Yeah. So now when I will move to solutions, then please put in questions for Zach, because we will, after presenting these different resources, need you to chime in with your thoughts and comments and feedback. If the goal in the COVID-19 pandemic is to provide trustworthy, accessible, and timely guidance in this evidence ecosystem, it would be great if we would be able to navigate evidence and guidance better. So there are a number of initiatives and resources, databases, repositories that could be relevant, and definitely I think are relevant for us. Question, of course, is whether these right now add to the infodemic or help us navigate. And we will look at some of the most prominent initiatives and discuss them, and we'll start with guidance. The big question is whether we can make the evidence ecosystem work better for COVID-19. And to help understanding, I'm going to present a conceptual framework that we have developed from the MAGIC Foundation together with Cochrane and many others to show where really I think we want to be. So for decisions in practice, etc., there are many resources, and we will have a look at this evidence ecosystem framework. So just imagine, and maybe you want to close your eyes and dream a little bit. When there is new evidence that could change practice, such as the remdesivir drug, wouldn't it be great if that evidence from trials was available to feed straight into systematic reviews, even a living network meta-analysis of comparative effectiveness across the drugs, and that could even happen within a week or two, and the data would feed straight into trustworthy and living guidance, whether it be health technology assessment reports, guidelines, decision aids, automatically disseminated to the point of care and to the target users in user-friendly formats. They could even be plugged into portals, pathways, electronic health records, local protocols, other tools that are used to implement guidance and decision support in practice. And this would be followed by immediate evaluation of impact on practice through more useful registries, etc. And this would be a loop. This is some version of what many also call a learning health system. And to make this loop work, it's actually quite crucial that we have agreement on what methods to use. For instance, using GRADE to assess the evidence from systematic reviews and to create trustworthy guidelines. The standards for trustworthy guidelines from the Institute of Medicine, or GIN. We would actually need to agree on processes as well, and we could use tools and platforms with digitally structured data to enhance the flow throughout this loop. And we also need to have a culture to share evidence and work and to innovate. So this is where we may want to be in this trustworthy, efficient, and well-integrated evidence ecosystem. Where do these resources, initiatives fit, and how could we work better? So now I'm going to start with one overarching initiative for the COVID-19 pandemic called COVID-19. And this is a nice new initiative driven from McMaster and Ottawa in Canada, where a lot of people have gathered to look at how we better could support decision making, and we want to reduce duplication and better coordinate evidence syntheses, technology assessments, and guidelines being produced. So you may want to look into this initiatives and join, and we have different working groups across scoping and engaging and digitizing and synthesizing and recommending and packaging evidence and guidance, all work in progress, but with the goal to support all of us working with evidence and guidance in the COVID-19 pandemic. This is just an example of some evidence sources gathered in Covident now, but the goal is not to create repositories here, it's rather to point to the best resources from Covident. So here you can see some sources of guideline recommendations, and I'll come back to these later in the presentation. So that's an overarching initiative. Now let's have a look at what we find at this step of the evidence ecosystem on the guidance side, and I'll present some initiatives and resources, and also some examples of guidelines that have appeared for the COVID-19 pandemic. Zach mentioned GIN, and we really want to do better and provide resources for COVID-19 in our website. And we have plans to update our library and the registry, and we therefore need your feedback in terms of what GIN should do. But you can see that, for instance, here at the website, we point to different relevant resources for guidance. Moving to another well-known resource from many of you, it's called ECRI Guideline Trust. It's taken over the role of the National Guideline Clearinghouse, and what they do is to score published guidelines for trustworthiness. If you look at COVID-19, they have a separate initiative. You can find 51 guidelines, but none have so far been scored as trustworthy for various reasons. I learned that some professional societies have not accepted ECRI to score them for trustworthiness, but there are definitely relevant and probably trustworthy guidelines you can find here. Hopefully they will score guidelines for trustworthiness, which is critical for us to know what guidelines are trustworthy and what guidelines are not. Moving on to WHO, they have their guidance on COVID-19 for, I think, 16 topics. One example for the question about high flow oxygen therapy is this guideline in the PDF format, and you can click and you'll find a weak recommendation to offer this treatment in selected patients. This is an example of a interim guidance from WHO produced rapidly, mostly leaning on experts in the absence of high certainty evidence, and it's quite brief. So I think what we'll see is more and more comprehensive guidance from WHO, coming more close to the standards for trustworthiness. So it's just basically recommendations and remarks and then references. WHO also commissioned rapid reviews, and they have their network to coordinate evidence syntheses in a better way as well. This is PAHO, the Pan American Health Organization, part of WHO. And what they do is very nice. They provide summaries of relevant systematic reviews and guidelines in different languages, even ongoing research through protocols. Here's one example where they point to recent papers on these tests, RT-PCR, and they conclude that it's at that point not possible to infer the sensitivity of these tests. Now, this just points to the fact that this is probably 2 months old now, or at least 1 month old, and maybe outdated in the pandemic with new research coming out. But a great resource, and maybe in particular for different countries and continents across the world who need translated guidance and evidence. NICE also produces guidance on COVID-19, and I talked to Paul Crisp, I think it's on the line, Last week, he was heading their guidelines, and he told me about a very interesting situation where they had completely transformed their approaches in terms of processes and much more rapidly producing guidelines. And you can click and find the relevant guidelines they have, targeted to the needs of NHS, and not that comprehensive so far. And if you look at intensive care, this is a nice flowchart of more policy systems decisions, not coming down to details in terms of what kind of ventilation therapy to offer, for example. But NICE really wants to share their evidence and guidance, and please reach out to them as to the others to see what they do in more detail. Moving on, Joanna Briggs Institute, JBI, the place where SAC works. They also have a COVID-19 special collection of evidence summaries, nicely targeting different groups of health organizations and professionals. For instance, the use of gloves and face masks for healthcare workers. So you find evidence summaries here that you can download. You may be becoming overwhelmed now. I'll give you a few more examples of guidance resources, and then we'll open up for questions. So please add questions to SAC as we go along, because many of the people leading these resources are on the call, so you could actually ask them if you want questions. What about trustworthy guidelines? Now, trustworthy guidelines is more than just a word. We have well-defined standards from the Institute of Medicine and GIN, stating that trustworthy guidelines need to be based on systematic reviews, balancing benefits and harms of the treatment alternatives. We need to manage conflict of interest, need to have the right people on the panel, and we should explicitly report the certainty of the underlying evidence and give clear and actionable recommendations. I think these are two guidelines that appear to meet those standards. The first, Infectious Diseases Society of America guidelines, providing recommendations for treatments and drugs, and all of them have the requirement that the use of these drugs should only be done within the context of randomized trials. Another guideline from the Surviving Sepsis campaign with 55 recommendations, very comprehensive for critically ill patient adults, provide, in this case, another weak recommendation to use the high-flow oxygen therapy in these patients rather than non-invasive positive pressure ventilation. So these provide actionable recommendations, again, based on low certainty evidence for these treatments. And I think these guidelines promise to become living, and living guidelines is really a hot topic for COVID-19. And here's an example of the first published living guidelines from colleagues in Australia at Monash University, heading a national COVID-19 clinical evidence task force. And you can see from their website that they do provide clear messaging about updated recommendations, for instance, on the drugs, on respiratory support, where there are new guideline recommendations, and they host their guidelines in Magic app, which allows them to move to living guidance and communicate updated recommendations in this platform. In this case, they give a strong recommendation if you have the infection control precautions in negative pressure rooms to use high flow therapy. You could click and you could find the great evidence summary table. You can even find decision aids if you want to discuss with families or patients in terms of this treatment. Then there are, of course, other resources for COVID-19 guidance. Maybe the most useful tools for busy clinicians is point-of-care resources, event textbooks, like Dynamed. You can see a picture here, up-to-date, best practice, event guidelines. And they also try to do their best in communicating updated and trustworthy guidance for these COVID-19 topics, which is a challenge because they maintain all questions in medicine. You have search engines and feeds like Trip database. It's really impressed by how easily you can find evidence and guidance there. McMaster Plus, where you can find and get feeds about new evidence. And then, of course, we have scientific journals and other resources. So there's a lot to look into here and to navigate in. Finally, before Zach will moderate a discussion on guidance, we shouldn't forget about health technology assessment and policy decision making. And Lucy Henry from HDAI is hopefully on the call, or her colleague. And this is one example of how this health technology assessment international network is working to respond to the COVID-19 pandemic. What they've done so far is to collate member resources online. They survey their members, and there's going to be a webinar 2 days from now that I encourage you to join, where you can learn a lot more about HTA and how that's working for COVID-19. It's clear that many of the interventions, the treatments we're offering, really demands health technology assessment in terms of cost, resources, organization of healthcare, inequity, and other things. So now I'll pause and I'll let you, Zach, see if there are any questions. Let's have a discussion about what I just presented before we move to evidence synthesis and evidence production in this evidence ecosystem.
Fantastic, thanks Per, and thank you everyone for submitting your questions as well. In the well-functioning evidence ecosystem, one of the cogs, Per, is a culture of sharing, and Kelvin Hill from Australia, he's asking whether or not you think the culture of sharing has improved or not during the pandemic. He notes there seems to be much more openness in sharing, but we are still duplicating COVID guidelines across the world. So is the culture really changing, or will it change? And is the current pandemic a facilitator or more a barrier to changing culture? What are your thoughts on that, Per?
That's a great question, Kelvin. I do believe this is a true opportunity to change our culture. I think it is happening. I see a lot of goodwill and interest in sharing evidence and guidance and work. Covident is one example where we quickly get many organizations to join, and it's such a positive atmosphere of willingness to share. I think the challenges are more practical issues around the way organizations work, the way they struggle to change, bureaucracy, vested interests, even in the academic community, are I guess also reflecting a culture that needs to change, but are real tangible problems in terms of solving the issues we're talking about today, in my view.
Thank you, Per. We've also got a question that's come in from Yusuf, and he's asking how valid and useful are these guidelines in low resource settings or countries?
Yeah, thanks for another key question. So what I'll come to a bit later in the presentation, I should have mentioned, is that I believe in the COVID-19 pandemic, we see more clearly than before that we need to collaborate on the global level on evidence synthesis and guidance, and then make it much easier to adapt the guidance down to, say, low middle income country settings. But we also should make sure that partners across the world are co-creating the evidence synthesis and the guidance. So how could we include people across the world and continents in creating the guidance and make sure it's fit for purpose, and then make adaptations, modifications, translations as needed. And I think WHO, through their network of experts from all regions, is one example of an organization who should be able to more rapidly produce and disseminate guidance for adaptation globally. WHO is now moving to Magic App for the COVID-19 guidance, which should make it easier to share and reuse and adapt evidence and guidance. But I think that's a core question. And how could we then support those of you, say, in Africa, creating guidance on your own? That's a core question for Covident, for example.
Great. Thank you, Per. And one more question. Louise is wondering, or she'd love to know more about best practice for developing living guidelines. And are there any resources out there on best practice for living guidelines, developing living guidelines?
Yes. So one of the things we want to do in both COVID and in GIN, and I think the resources for guidance should provide, is updated standards and methods for guidelines, including living guidance and living evidence. And I'm not sure if we have people from the Living Evidence Network from Cochrane on the call, Julian Elliott or Britta Tendal, or maybe someone else could speak up about the most recent guidance for living evidence and living guidelines.
Britta is on the call, but I'm not sure I want to put her on the spot at the moment. But maybe if she raises her hand, I'll unmute her later on.
Yeah, or Kelvin, who did the first stroke guidelines to become living, may want to speak up to this. But I think what we really want to do is to put up guidance on standards and methods for living.
Hello, everybody. This is Britta from Australia calling.
Thanks, Britta.
Just going to check if you can hear me, but apparently you can. All right. Yeah, so what would you like me to say, Pierre?
So I think the question was standards and methods and processes for living guidelines. Do we have any guidance for that, or do you have any guidance to share?
Well, we're developing some documents right now that we're going to use because we're seeking NHMRC approval here in Australia, and that requires us to actually think and put some of our thoughts down to paper. So there will be some soon that we can share, so that we're very happy to share those. I won't say that they are how you should be doing it across the globe, but it might be some guidance. And also, yes, the stroke guidelines have some really good stuff out there. And then obviously Cochrane collaboration have some for reviews, but that might also actually be quite applicable for this situation with guidelines. So yeah, happy to help in any way we can.
Thanks, Britta.
And Kelvin also, I think, has some comments. So Kelvin, would you like to share your experiences with living guidelines?
We all need to document further. I mean, we've been testing one model of how to do it, but there's several ways to skin a cat. So as Britta mentioned, I think we're at the point now where we'll start to see some publications and some sharing and refining of those methodologies within the community. But there's not too much out there as far as I know yet, but keep a watch, should be soon.
Great, thank you, Kelvin. And Per, that's all the questions for now.
Okay, so I can move on. We are now going to step backwards in the evidence ecosystem, which means that there are also very nice evolving resources for systematic reviews and studies and what's called evidence maps. And these are, I think, great value to guideline developers. So I'll take you through some of the most prominent initiatives, and then again hope to have a discussion and get some feedback on how you think these would work for you in the COVID-19 pandemic, and I think also beyond the pandemic. So starting off with Cochrane, of course, a core organization for systematic reviews. They have invested heavily now in COVID-19. They're turning their systematic reviews into living reviews. And I was very impressed about a week ago to learn that there will be living reviews for diagnostic test accuracy, such as the question for tests we mentioned, for prognosis, and for treatments. They also have databases of studies and evidence maps that I will present very soon. So a lot of offerings from Cochrane to contribute to COVID-19 crisis and how to deal with it in terms of systematic reviews, etc. This shows the study register, which is actually a number of studies, and they are coded, and should be possible here to search and find relevant studies for COVID-19. And Chris Mavagames is on the call, a dear colleague obsessed with the technology and digitalization, so he may speak more to how this resource works and how you could search and find evidence in here. And this is a very exciting initiative. It's called Living Mapping and Network Meta-Analyses. It's driven from the French Cochrane Center with many collaborators, and it shows published studies, systematic reviews with network meta-analyses. Also point to some guidelines, but that's not very extensive. But I'll show you how this looks. So you can actually go here and find a lot of different treatment comparisons in this network diagram. You can see these are for patients with mild or moderate disease. And you could go in and select comparisons. So if I want to look at, for instance, hydrochloroquine that Trump is now using, this is the evidence, maybe not fully up to date at this moment because there's just been some more trials. Basically, they will provide even grade evidence summaries. Here you could see missing data for most outcomes and no compelling effects for mortality at that time, just one randomized trial, very low certainty evidence. But it's really impressive to see how you could, when this is living, you could get access to updated evidence to inform the guidelines. And this is actually what I think Australia is doing in their living guidelines at the moment. So lots of collaborators, very impressive effort, may be a great solution for those creating COVID-19 guidance and HTA. Moving on to another promising resource. This is the live map of COVID-19 evidence from the Norwegian Institute of Public Health. It reports studies and systematic reviews. The plan is to include guidelines through a collaboration with McMaster from June. But it is really interesting to see how these maps could work, I think, because this is very comprehensive. You could look into all sorts of questions, from prevalence to etiology to diagnosis and treatment and prognosis. And the bubbles show how many studies in red, how many systematic reviews in green, and non-systematic reviews in blue there are for each topic. You could also search in detailed categories, and I think that's a strength. So you could go into diagnosis and just look for systematic reviews. And here you'll see a big green bubble for diagnosis. And I click on that bubble, and I find quite a number of references. So I do need to scroll a bit. But this is an updated systematic review on these tests, RT-PCR tests. And I could easily find the kind of information I need to know. I have to read the full text and assess its quality. It just shows that the positive predictive value is quite variable with a very high negative predictive value of this test. So in this map, you will find hopefully a pretty complete picture of reviews and studies, and you can find them and make use of them for your efforts. Moving on to a third interesting resource called LOVE, Living Overview of Evidence from Epistemonikos. This is the biggest database of reviews in the world, I think, but they also have a specific effort on COVID-19, so you could find systematic reviews, but you could also go to their LOVE resource. And here you could build questions using the PICO format. And in this case, you could look at specific topics such as diagnostics. And I did a quick search, found 23 systematic reviews on diagnostics, and quickly found the same meta-analysis of these tests I was looking for. And then you can click and easily find the publications. None of these yet provide me with what I really would like to know, that are these high quality, trustworthy systematic reviews or not? And I think we have people from NIPH and Epistemologos and Cochrane on the call, so they may want to correct me if I'm wrong, and I'm sure they have plans to filter the high quality reviews for us. That's a question we should address. Moving on to WHO. Here's their database on studies and systematic use and guidelines, published and ongoing. That points to another question, because I think all of us doing guidelines would want to know what's ongoing, what's planned, what's in review, because or else we may easily start doing our own work unless we know something good is coming up very soon that we could reuse. Here's evidence aid, providing nice summaries of systematic reviews, both on health and other outcomes and conditions, translated to many languages. And I think we have someone from evidence aid on the call, and it's very nice how they summarize evidence on important topics here, pointing to a rapid review, and again showing how challenging it is to be up to date, because now there are more studies on chloroquine and hydrochloroquine, which makes it challenging to keep our resources up to date. Finally, there are, looking back to the trials and the research repositories of trials such as this one, showing ongoing trials and at what stage they're in, what they're comparing. Very nice infographic here to show where these trials are happening. Here's another one, COVID evidence database in a beta version, with the same goal to provide a nice overview of continuously updated database of ongoing and published trials. And finally, just to remind ourselves that there's been an explosion of research for COVID-19. We need to expect waste, but there's also emerging goal. So WHO solidarity, discovery, recovery, these trials are so-called adaptive platform trials, comparing different drugs. And I think we'll see high quality, low risk of bias evidence coming out from these trials that we could transform into evidence synthesis and guidance. So now I'll pause again and see if there are questions, Zach, from the audience about systematic use and studies from the audience.
Thank you, Per. Before we get into the questions, I believe Stein had something he'd like to add for the NIPH resource. And particularly, I think he was going to explain to us how they're doing their evaluations as well. So, Stein, I've made you a panelist, so you should be able to contribute now.
Yes, thank you, Zach, and hi, Per. Thank you for organizing this most relevant and excellent webinar. So first, a small addition to the summary of the Norwegian initiative. In addition to categorizing the evidence, we are also planning to add quality assessments for prioritized studies. And that might also be of interest for all those producing guidelines. So that's another aspect that could be shared, and we expect that the first quality assessments might be added in June. That's part of an ongoing review on mental health in healthcare workers. And then on the other topic you asked, we think that the evaluation of completeness and quality of categorization in evidence maps is an important thing. And from April onwards, we have started evaluating this by comparing with randomly selected systematic COVID-19 reviews and comparing those with the content if we have the studies in our map, and then I mean the primary studies quoted in those systematic reviews, giving us an idea of the completeness of the initiative, but also evaluating if the questions from that systematic review in relation to the PICO are categorized in the right spot on the map, meaning that if evidence synthesizers would use the map, if they would be able to find what they want through this initiative. So we've started doing this in April. We'll continue to do that for every update of the map. And this gives us the idea that the map is complete on peer-reviewed studies, and also the categorization is robust and of good quality. What is important to add, and then I'll just get back to you, we do not include preprint databases like medRxiv. They contain preliminary reports, has not been peer-reviewed yet. Most important ones will move into the database afterwards. And so that should be clear that that is not part of the database at this point. Thank you.
Thank you, Stein. Did you have a response?
Yeah, no, I think since we have Cochrane folks, Catherine, Marshall, I think others, Chris, we do have time for you to explain more about your resources and plans. So please raise your hand, and Zach can unmute you. I don't want to put you at the spot, on the spot, but we definitely have time for more questions from you in the audience, and for those behind the resources to explain better. You know, I may have misrepresented what you're doing at first. So anyone want to speak up, please tell Zach. And Zach, maybe there are other questions meanwhile.
Yes, so whilst everyone builds the courage to speak up, we did get a question along a similar line to what Stein mentioned about the issue of preprint studies, and particularly those in medRxiv. And what the thoughts are about these preprints, and whether they should be included in reviews by some of these organisations, and how trustworthy they are, and if you had any thoughts or opinions about this.
Great question. And I didn't come to this yet, but I think this is going to be the topic for the next GIN webinar on COVID-19, actually. We believe Christine Lane from Alison Internal Medicine is going to talk about preprints and the challenges and opportunities through those. And I think remdesivir is a good example of a new drug that actually has entered practice in the US, at least, based on a press conference release, the data. You can imagine that they've made the preprint available, making it a bit easier for us to interpret the evidence before the trial is published and having gone through peer review. I wouldn't trust a preprint if I'm responsible for trustworthy guidance. So we do the BMJ recommendations, and I'll come back to how we're going to deal with remdesivir now in a living guidance mode. But we would wait until the trial data is published in a journal. But you could definitely start preparing, I think, and you could do evidence synthesis and guidance. And in our approach, we wait to publish any guidance before we have seen the published peer-reviewed literature out there. I think it's a core question, and preprints are great, and I think we need the same for systematic use and guidance, not only for trials and studies. And I think that's a key question, whether, you know, who could host that, how would it happen? So again, that's a promotion for the next webinar, I think, to deal much more deeply with that issue.
Fantastic, thank you, Per. Chris Mavergames has put up his hand, and I think he might be able to add to some of the work that Cochrane are doing at the moment. Chris, would you like to share?
Yes, I hope you can hear me. Hello, wherever you are in the world. Yeah, I can say a bit more about some of the work Cochrane is doing. Just on that question of preprints, we just concluded, literally hot off the presses overnight, Robin Featherstone in our editorial unit completed an evaluation of the Cochrane COVID-19 study register, which you showed earlier, Per. We wanted to look at what the sensitivity was so far. And of these, I'm just looking literally at the data right now, of the 373 included studies in recent reviews, these were DTA reviews, some of them not published yet, pharmacological reviews, etc. We found 47% of the included studies were preprints, which was staggering number for us, and which meant that the direction we were heading for the register, which we started about 2 weeks ago, adding preprints from medRxiv, was the right direction. So our sensitivity wasn't that good due to the lack of inclusion of preprints. So we are working as fast as we can to get the backlog of preprints into the register, as well as a tranche of 2,000 letters that we've identified. So just to mention that about preprints, I mean, the implications of that are, of course, quite interesting, and yeah, could be a whole webinar probably. But just to mention that, in terms of the register, yeah, we've just cleared 5,000 studies this morning, working through the backlog and tagging and annotating the pharmacological RCTs as quickly as possible for PICO, and looking at what other metadata we can add to the other study designs. But we have the basic study characteristics and are starting to surface other fields that we're capturing and curating, such as source or funder, and the other one that I'm forgetting because it's too early and I haven't had enough coffee. But we're constantly enhancing it, and it does have search and export and fairly decent faceted browsing that we hope can help folks identify studies as quickly as possible. But it is, I must say, it's a challenge to keep up, updating PubMed and ct.gov daily, ICTRP as soon as we can get the information. And now with the inclusion of preprints and other sources, it's an absolute explosion of research. But yeah, I think that's where we're up to right now.
Thank you, Chris. And I guess this is probably a question for both you, Chris, and you, Per. So given this explosion in research and preprints and everything else at this stage, what are some of the challenges for rapid guideline development and also living guidelines when there is just this constant explosion of evidence?
Yeah, I could start. I believe in terms of rapid guidelines and rapid reviews, the core question is whether we should allow ourselves to jump corners. I think WHO commission rapid reviews, and I believe Cochrane does, and others not commission reviews, but do them quickly without jumping corners. And I think that's crucial. I would be very concerned to build updated guideline recommendations on rapid reviews, not representing the evidence well enough. Then it's a huge challenge because there's duplication of efforts, massive duplication. I'm guilty as charged in doing a rapid review for WHO that we didn't register in Pulse-Pro, which means probably 10 others did the same on high-flow oxygen therapy, and now it's going to be published eventually. So rather than jumping corners in rapid reviews, and I would also say rapid guidelines moving forward, we should collaborate and make sure we have access to updated evidence. And I've shown you some resources that I think will be really promising. One of the challenges for those of us doing guidelines is that often the system managers don't answer the panel's questions or the clinical questions and the patient's questions. So we don't find the right outcomes for the evidence from the reviews, which speaks to the idea of a very tightly coordinated effort. Cochrane is interested in this, and many others to make sure that what the Cochrane reviews answer is what the guideline panels need. And the same goes for HDA. But it's really, how do we now coordinate efforts in updating the databases for trials and systematic reviews and guidance? How do we assess their quality and trustworthiness? That I don't think we have the answers to, but I think this call is a way to discuss how to move forward. Because what we are saved by in some way now is the fact that we only have low certainty evidence to inform basically all decisions of COVID-19. But there will be more useful and reliable and relevant evidence for COVID-19. So then suddenly it becomes much more important to assess that evidence and transform it into trustworthy guidance than before. Imagine you have high quality trials on the drugs, and then suddenly it shows hydrochloroquine does not work how do you quickly transform that into strong recommendation against the drug to avoid waste in practice and harm? So that would be my first response to that important question, and maybe others want to chime in, or Chris, any thoughts on the review side?
I mean, one of the things I would say about what we're talking about in the COVID initiative, which you mentioned, the digitizing group, and generally is in terms of duplication of effort around identification of studies and trials. We're currently tracking, our team are tracking a spreadsheet of all of the study portals that we're aware of, and there are 41. So you would have to have a few more slides in there to cover them all. And what strikes us about them is they all have different use cases of different variations, some of them very similar, different inclusion criteria, but which is fine. And I think some duplication of effort is inevitable, but what we could be doing and what we're discussing is using IDs, trial IDs, PubMed IDs, and other basic information, exchange metadata, so that where tagging and enrichment or quality assessment, whatever the curation that's going on, could be shared across the different records, because I think people will still collect collections of studies, of course, for their use cases, and that's right, and that serves that purpose. But what we could be doing is sharing the metadata about those trials, and we're going to be discussing in our call this week how we further look at doing something like that. In terms of reviews, yeah, registration in Prospero, Cochrane has its question bank on the COVID Rapid Review site, where we've been listing all of the questions that we're gathering and trying to prioritize and then show the ones that we have in progress. I don't think any of my editorial colleagues from Cochrane are on this call, but I know that some of them are joining the call, the other webinar today. And I'm less close to that work, but we have been trying to at least transparently show what we're working on, and working with others to coordinate as much as possible. But yeah, those are some of my thoughts on that.
Great, thank you, Chris. I guess it comes down to that old discussion about accelerated versus abbreviated systematic reviews, and one approach is to use shortcuts to create reviews rapidly, and the other approach is to collaborate and perhaps use digital technologies to help get them done quicker. And ideally would be doing quicker reviews and quicker guidelines, but still high quality and trustworthy. But David Tovey is also on the line, and I think he's going to tell us a little bit more about COVID End. David.
Thanks very much. I hope you can hear me. Yeah, Bear's nodded, good. I was going to what first thing I just mentioned in passing about preprints, really. I mean, one of there's clearly a massive explosion area that has really taken off during this pandemic, and fantastic resource, as everybody's saying, but with some real risks, I think. One of which we came across in the Paris Network Meta-Analysis project, where two of us did assessments of a medRxiv article about a week and a half apart, and I was the second person, and I couldn't understand why all my readings disagreed with the others, and it turned out that all the data had changed because the study was ongoing and they were still adding new people. So the text was the same, but the numbers were different, and I guess that's a warning for people if it wasn't very clear that the study was still ongoing and they were still going to be adding data. And I suspect they've added data since. But it was just a weird experience. Never had a paper change in front of us before. In terms of COVID End, I think one of the great things that COVID End has done is to really think about how we're going to deal with the duplication of effort. And I guess we thought about that at the outset in terms of trials. But listening to this fantastic webinar today, it's clear is that there's this massive proliferation of work in every field, both trials, evidence synthesis, guidelines, HTA, and so on. And COVID End exists to try and reduce inappropriate duplication, but also to sort of bring groups together to agree standards and to agree processes and so on. And I suppose one of the questions that I have the groups really thinking on this is, to what extent can we expect people to collaborate when we talk to people, everybody says, well, of course, our first priority is to the work we're being paid to do via, as part of Cochrane or as part of any other organisation. But we've talked about a number of things in this webinar about where there's obvious opportunity work that isn't being done. The study assessments that NIPH is now thinking of doing. And I just wonder whether there are more opportunities for collaboration and sort of breaking down the boundaries of organisations somehow, and whether COVID-19 can support that in any way, whether that's something that's safe for people to take on, or whether it's something that would be perceived as too risky.
Great points, David. And please visit COVID, and we'll share the slides for you, and we'll get the link to COVID in there as well. As for the other resources, you can easily click and find information how to hook up with them. Zach, any more questions?
So Stein said that he'd be happy to add a little bit more detail as well about the NIPH evidence map. So Stein, would you like to provide a bit more detail?
Yeah, thank you. And I also want to respond just to the previous comment. I want to thank you, Zach, for informing about our call for collaboration that we have through the Norwegian Institute. We really aim to make this initiative a critical public good. So everybody who has an interest in this can collaborate with us and can help us to achieve also the objective of adding critical appraisal for prioritized studies, and that would be absolutely great if we could achieve that. What I also wanted to add is that in addition to the level of completeness of a database and the correctness of the categorization, which of course is important for all those that would like to use maps as a starting point for guidelines or evidence synthesis, and that would already be a massive reduction in duplication of effort if people stop screening themselves but use the maps as a starting point. If they are of good quality, that should be assessed. But then also comes the aspect of detail. How detailed is the level of categorization? Is that a high level or really going to the PICO? Because that affects the number of references that you need to screen for an evidence synthesis and reduces again the amount of work. So the approach we've taken within the Norwegian Institute is we have a hierarchical approach with 3 levels, moving from, for example, etiology to modes of transmission, to transmission through surfaces, human to human, and so on. So that really allows you to go down to your precise question. And I think that's also important to consider. Thank you.
Thank you, Stein. Yes, Per.
Could I check it, because we have some other representatives from these resources on the call. I don't think there's anyone from WHO, but Paul Crisp is on from NICE. So I wonder if, Paul, you want to comment or explain more about NICE and what you're doing on COVID-19 now. Again, don't want to put you too much on the spot, but you are definitely doing a lot of work on this. So Zach can allow you to speak after you if you want to.
So Paul, if you're comfortable and if you're there, just raise your hand and I can make you a panelist for this discussion. Very good. Okay, please, Paul.
Good morning, everybody. Yeah, thanks. It's a really good way to start the day, this webinar for us in the UK. So yes, I think our experience at NICE has been to go hard and go early with our guidelines. And your point, Per, about speed versus quality, that tension, we resolved at the outset that what the NHS needed was some guidance to be developed rapidly. Our interim process and methods is up on our website. You can see, given the speed that we had to move, we had to produce 3 guidelines in a week. the approach, therefore, was based on reusing existing guidance as far as possible, adopting a very targeted approach for our literature searches. So starting with what the WHO had produced, looking at other guidance that had been produced by other bodies in the UK, and then looking at guidance that had been produced by other organisations accredited by NICE. So that was our start point, and then working down through the Cochrane database of systematic reviews until we then augmented that where necessary with expert input. So working very closely with leading clinicians in their specialty areas. So by its nature, it was this guidance was very much tilted towards getting some guidance out there very rapidly. And what we're finding now is that we're kind of mopping up as the evidence builds. And this has been mentioned by a couple of other speakers, as that evidence builds, we're mopping that up into our routine surveillance and updating of the guidelines. And interestingly, we reckon about 50% of the recommendations in the 19 guidelines we've produced so far are service and operational delivery, and about 50% are intervention based. And we're going to concentrate on the latter because that's where the evidence will be generated. That's where we're going to place our efforts. The outcome of that reviewing and surveillance is likely to mean one of three things. One, the guidance is very time limited and can be stood down. Two, it could be assimilated into existing pathways and existing NICE guidelines as a facet of the management of patients with that particular condition. For example, in asthma or COPD as examples. And the third option would be, are these guidelines discrete and unique enough to stand on their own 2 feet and be maintained as a separate guideline in their own regard? So that's the approach we're taking, and my colleague Nicole Taskey, who'll be joining this afternoon's webinar, has been leading on our efforts to work with the COVID End Group, WHO, Cochrane colleagues. So we are very much tapped into and support the international collaboration that this work will hopefully unlock.
Great, thanks, Paul. Now, I think we'll move on, and there's going to be a final discussion on how Jim can contribute. And if anyone else, and so many knowledgeable people on the call may know about other resources and initiatives, so please raise your hand, and Zach can unmute you in the last part of this session. So let's see. Can you still see my slides, Zach?
Yes, we can still see them.
So moving on with a summary, I think, from this discussion, and a few thoughts before the last round of discussion. I think it's fair to say that for those few and selected questions we have been looking at, we can find, I think, both trustworthy evidence, high-quality reviews, and guidance for our questions. We did not look specifically for HTA reports. I'm not sure what's out there. But it's still, to me, it's quite challenging to navigate, and I think it could be for others. Again, I think we're saved by this low certainty evidence across basically all measures taken for the pandemic. But again, a lot of research is going on, and also high quality trials and studies to provide much better evidence to inform decision making. So we need to keep on top of the evidence in a good way. In terms of these resources, as David Tovey pointed out, there's a lot going on. We may contribute to the infodemic unless we're able to coordinate and support each other. There are some really promising resources for studies and evidence syntheses. I still think we need to provide similar resources for living and trustworthy guidance. Something we're interested in Jim to contribute to. Maybe these maps will provide the best place to go to. And again, in terms of avoiding duplication of efforts in evidence synthesis and guidance, I think in particular for guidelines, if we know what's going on, what's being planned, what's ongoing, what's in review of guidelines, it would be much easier to wait and adapt and reuse the evidence and guidance than doing your own effort. And I'm, as I said, perhaps guilty as charged in our rapid review for WHO a month ago. For these resources, we definitely need rigorous evaluation, and some of these are now using machine learning and artificial intelligence. So to what extent they're complete and useful, I think it's the next step. And I know the Institute of Public Health in Norway is doing this, and it should be independent across resources. I think Covident is interested in contributing, and that's something to pursue. And then, of course, we all are challenged by capacity and funding to scale up and maintain these resources. I want to stop with an example of another initiative to give you a picture of how we could work in this evidence ecosystem. And I'm sure there is a lot more ongoing under the hood. And please tell us about initiatives we've not been able to capture and that could be relevant to share. So closing off, having looked at these scenarios, I'll give you one example of how I think we could work efficiently in the evidence ecosystem. And this is, as a disclaimer, something we're doing now in our magic BMJ rapid recommendations. And we hope to do also together with WHO. And if you take the case of remdesivir, for example, or drugs, treatments, if you have a living systematic review and network meta-analysis of all these treatments, it should be feasible within a week to provide a fully updated evidence summary from that systematic review that would be answering the question from a standing guideline panel that's been established up front. And they would produce their guideline recommendations ready to submit public review, peer review within week 2 or 3. And it should be possible to disseminate this on a global level by week 4. And I think if we're not jumping corners, that's about as fast as I think we can be. And then, of course, the use of platforms to create and publish and produce living guidance. The use of BMJ here to provide nice and user-friendly publications. Australian living guidelines already doing this for living network meta-analysis, updating on a weekly basis, and then being able to work with countries, such as we try in Norway, to integrate health technology assessments in a coordinated process, not to lose time, to add cost effectiveness, etc., and then to take this into practice, into hospitals, healthcare systems, in a very closely coordinated process. If we somehow could use these resources you've seen to make this happen, and then have other people to join in the process of what we call co-creation, so clinicians and methodologists and patients across the world will be part of this effort to make sure we get the questions and the answers right. I think this is the approach we're taking, and we will definitely learn from. But it should also be a way to curb the COVID-19 pandemic and infodemic, we hope. So, final discussion, back to you, Zach. Ideas for how we in JIN can contribute to make your life easier and to tackle the COVID-19 crisis.
Great, thanks, Per. And whilst we wait for some further questions to come in, we had one that was submitted that asked, or said they're a bit overwhelmed with all of these initiatives. So where is the best place to start for a guideline developer?
So I believe that right now, if you're looking for best current evidence, I think the evidence maps and this the living systematic reviews that I've given you examples of would be a really good start. For one place to go to find the most relevant and accessible and trustworthy guidance, there's work to be done. And I believe we will try in JIN to now rapidly develop our new registry and library of guidelines. Then you have the Equity Guideline Trust, and you have the maps promising to also include guidelines scored for trustworthiness. I hope we will see that soon, but I think we just have to also evaluate how these resources work, how useful and complete they are. So I'm afraid I don't have myself fully informative answer to you, but I think this is where we want some input in terms of, okay, how could we together make sure that it's easier to navigate evidence and guidance in this crisis?
Yeah, thanks, Per. Just on the living evidence maps, how do we know if they are valid and reliable enough so that we can use these rather than searching elsewhere or searching the databases?
So that would be a question to those responsible for those evidence maps. And I know that there is ongoing evaluation of these resources, and they show to be more or less complete. And again, if you go into this evidence map and you find an updated systematic review, there are definitely tools to assess how good they are. And same goes with guidelines. If you find this surviving sepsis campaign guideline and it's up to date, you can assess using the IOM standards, the needs instrument, or agree to see if it's a high quality and trustworthy guideline. And then you could, I think, rely on that to adapt and reuse for your purpose. But that's why we need this evaluation quite badly.
Yeah. So it's there's a question coming in from Catherine Marshall from Cochrane, and also a GIN patron. She mentions that Cochrane is developing an initiative to involve consumers in the COVID-19 rapid reviews. Has anyone else involved consumers in their COVID work? Do you know?
Thanks, Catherine. So David Tobey may speak to this from COVID, because we have been discussing how to better involve consumers or patients, citizens. I think for the BMJ rapid recommendations, we have patient representatives in our panels, and they're participating throughout. That's a very specific initiative. To what extent they are taking part in the evidence mapping and the living systematic reviews from other sources, I would have to see if anyone wants to speak up representing those resources to answer that question.
Okay. David, I've just unmuted you if you'd like to add a little bit from the COVID end perspective.
Well, this came up very early in our conversations as a really important aspect of our work. And to be honest, we looked around and struggled to recognize how to do this better. So, I believe the current plan is to carry on conversations with Cochrane around this because of Cochrane's activity that we've become aware of. I think we're very much aware of this as an issue, and indeed the issue that came up earlier in the webinar about geographical diversity in general. These issues are important to us, but at the moment, I'm not sure we have a solution, but we are actively seeking one.
Okay, fantastic, thank you. And is there anything else you'd like to add about COVID end at this time as well before we move on, David?
Well, just the intention of COVID end was to try and get across the breadth of the work that's going on, and to be inclusive, and in particular to recognise the challenge that Per talked about earlier about low-income countries, and so that if there are people representing organisations that haven't become aware of COVID end yet and who would like to get involved, and I would strongly encourage you to contact us, and I would be very happy to give out my email or to put people in contact if that would be useful.
Great, thank you, David. And Paul from NICE also has some comments on patient input. Paul?
Yeah, hi. So we haven't involved advisory committees to develop the rapid COVID guidelines for obvious reasons, because of the time taken, but we do have a targeted consultation phase for these guidelines, and we do reach out to relevant patient groups to get input. And we have to say the level of engagement and participation to get consultation comments has been fantastic. You know, the whole system is sensitized to respond rapidly to any new evidence and guidance coming out in this area. So people are teed up and ready to go. You know, we have on average had about, you know, well into the hundreds of comments from, you know, 20, 30 different organizations, clinical and patient groups on each of the 19 rapid guidelines. So that's another thing that you could consider when you're developing guidance in this area, is to reach out to patient groups at that peer review stage and get them involved there.
Thank you, Paul. And Duncan Service from Sign and Gin has just also mentioned that Gin Public are looking into this as well. So this is another area where Gin can contribute also. Per, is there time for some more questions, or would you like to sum up?
There's time, I think.
Okay. So there was a question regarding the use of grade to assess the evidence with the evidence we're seeing at this time, and whether you had any thoughts about grade and using grade at this time.
Yeah, so of course I'm probably biased by my work in MAGIC, which stands for making grade the irresistible choice. So I really think that it is the optimal methods to assess the best body of evidence and produce the relative and absolute effect of treatments across the outcomes and rate the certainty in a systematic and transparent way, and then move from evidence to recommendations accordingly. And I think also the platforms we have with RevMan and GradePro GDT and Magic App makes it much easier to share digitally structured evidence and recommendations. So it's really coming through as an appropriate method for the COVID-19 pandemic. And as you've seen in this wonderful French living NMA evidence map, once you create those tables using grade, you can see that the trials don't report the important outcomes and explicitly state that we have low certainty on critical outcomes like mortality and hospital length of stay. So, well, I'm biased, but I do think we can use grade fully now, and it's an easier way to share and update evidence and recommendations across the bodies.
Fantastic. And perhaps our final question before we finish up today, from Louise. We spoke about not cutting corners in guideline development, but are there some aspects of a process we should try to do differently in the interest of time?
So I think the core challenges really are making sure you have a standing guideline panel assess for conflict of interest, knowing what they're up to, and then doing rapid evidence syntheses, and then moving through the process of creating recommendations, getting teleconferences, people pre-planned, and then the peer review and public review and clearance process is what typically does require time. And I think Paul, Chris from NICE mentioned that it is possible to totally innovate the way we work, and it's now more needed than ever. And that's a major challenge for organizations stuck with their standards and processes, but it's possible. I think when you see the way NICE and WHO has turned to much more rapid production of interim guidance, this example, it works even for the biggest organizations. So it's possible. Rather than jumping corners, we should just innovate the way we update and disseminate our guidance.
Yeah, fantastic. Okay, did you have any last comments, Per, before we finish up for today?
No, just I guess you're going to thank everyone, but it's really been great with all the questions and input we've gotten. So thanks so much.
Yes, well, I'd like to echo those sentiments as well, and just thank everyone for coming along today. And I'd also particularly like to thank the Secretariat at GIN, who did a lot of work putting this together, and particularly you, Per, you've led this webinar very well, and I know you've got another one in about 6 or 7 hours. So thank you for this. Thank you all for your contributions today. We will be recording this and uploading this to our COVID webinar page, so you can see it later. And we will be sending out a short survey as well, just to get some feedback, and we'd really appreciate if you could fill that in. But Otherwise, thank you again for your time, and we will be in touch. Thank you all.
Take care. Bye-bye, everyone.